My name is Brandy Holcomb, and I am presenting a case study on a patient that presented to the cardiac cath lab. Mrs. S&M is a 75-year-old female whom has had an abnormal stress test that was then referred later for left heart catheterization, which revealed left main coronary disease and is to be evaluated for coronary artery bypass grafting with Dr. William Turner. History of present illness. Mrs. S&M is a pleasant 75-year-old female that is being evaluated for coronary artery bypass grafting with Dr. William Turner. She has a long-standing medical history significant for coronary artery disease, hypertension, diabetes mellitus, dyslipidemia. The patient denies chest pain and pressure as well as shortness of breath at rest and exertion prior to her initial cardiac workup. She denies syncopal episodes. However, she does describe an event to where she was driving and became disoriented. She states that she was seen by her primary care physician and was told that the, quote, crystals in her head were abnormal, end quote. She also goes on to say that she had dizziness with this aforementioned episode, but denies fainting or loss of consciousness. She denies recent or remote tobacco usage. She provides a vague impression of her activity level at home, stating, I don't really exercise, but I do a lot of quilting and sewing. In addition to a substantial amount of clonidine for hypertension, she takes isosorbide and Coreg. She does have diabetes mellitus, admits to checking her blood glucose regularly, and states that she is controlled with a blood glucose in the, quote, 120s, end quote, at home on her 4 oral medications. Her most recent hemoglobin A1C is 9.1. She states that both her mother and her father died related to complications following myocardial infarction, and she has had 2 brothers die of cardiac-related disease, including one brother with an aortic aneurysm dissection and acute myocardial infarction. Review of systems. Systems review as outlined prior. In addition, she denies any anorexia, weight change, fever, fatigue, or malaise. She denies auditory and visual disturbances, no headache, postnasal drip, sinus pressure, rhinorrhea, or epistaxis. She denies nausea, vomiting, constipation, and diarrhea. There is no history of GI blood loss. She denies hematuria, dysuria, or bladder pattern irregularities. No palpitations, no lower extremity edema or claudication, no orthopnea, P&D, cough, sputum production, or hemoptysis. She denies hepatic and renal dysfunction, no endocrinopathies, no history of CVA, seizures, or syncope. No focal neurological deficits, paresthesias, paralysis, or ataxias. No cutaneous manifestations, myalgias, or arthralgias. No history of bleeding, diatheses, or thromboembolic disease. She is a 75-year-old female, height 1.65 meters, weight 96.6 kilograms, with a BMI of 35.4. Body surface area is 2.03 meters squared. For her physical exam, vital signs are as follows. Blood pressure 130/74, sinus rhythm 64 beats a minute, temperature is 36.7 oral, respiratory rate is 18 unlabored with a SpO2 saturation of 97% on room air. Generally, she is alert, oriented, well-developed, and appears to be in no acute distress. Her skin is warm, dry, mucosa is pink, and there is noted to be good skin turgor. No rashes or lesions are identified. Pupils are equal, round, and reactive to light, approximately 3 millimeters. Her sclera are clear. No oculo, auto, or rhinorrhea is appreciated. Posterior oropharynx is without erythema and exudate, and glottic opening appears of normal caliber. Her neck is supple without jugular vein distension. Her trachea is midline. There is no thyromegaly, no carotid bruit, nor lymphadenopathy is appreciated. Cardiac, her rhythm is regular with a positive S1 and S2. No S3 or S4 are appreciated. No murmurs, gallops, rubs, or clicks appreciated. Point of maximum impulse is non-displaced, and there is no tactile fremitus or overt precordial heaves identified. Her chest is clear to auscultation with good air exchange throughout. No accessory muscle use with respirations. Diaphragmatic excursion appears normal, and chest expansion is equal bilaterally. Her abdomen is soft and non-tender. Bowel sounds are present in all 4 quadrants. No masses or pulsations are identified, and there is no appreciated organ megaly. Her extremities, there is no peripheral pitting edema. Peripheral pulses are present in all extremities and equal bilaterally. There is no digital clubbing nor cyanosis noted. Cranial nerves 2 through 12 are grossly intact. She moves all extremities well without focal deficits or ataxias. Grossly normosensory in all extremities. Today she had a diagnostic left heart catheterization. The differential diagnosis: coronary artery disease involving native coronary artery of native heart without angina pectoris. Plan for Miss S&M's management will be a preoperative risk stratification workup, a beta blocker, aspirin, an ARB, statin, nitroglycerin, and unfractionated heparin as indicated and tolerated. We will wean her clonidine and increase her Coreg. We will obtain a PA and lateral chest film series, carotid ultrasound, an echocardiogram, pulmonary function tests, a hemoglobin A1C as her previous A1C is over 1 year old. We will place her on a sliding scale insulin, and she is referred for urgent cabbage on the 8th, February the 8th, 2016 with Dr. William Turner. In summary, Mrs. S&M is identified in the Lewis and Peaches Owen Heart Hospital Outpatient Cath Unit, room 160, bed 18. Her 2 sisters are at bedside. She was referred by Dr. Flaskus by her primary care physician for stress testing, which was abnormal, and sent for left heart cath today, which has revealed a 70 to 80% left main coronary artery disease, a 30 to 40% proximal LAD. Her OM stent is patent, and the right coronary artery is noted to have mild diffuse disease. Other than the aforementioned history and diagnostic findings, Mrs. S&M has been in her usual state of health until today. Thank you for this consultation and allowing us to take care of your patient. We will continue to follow Miss S&M throughout her hospitalization, updating plan of care as the patient condition dictates and as further information becomes available. Signed, Brandy L. Holcomb, BSN, RN, AGACMP student, University of Texas at El Paso. Thank you.